into the subarachnoid space. The cardiovascular accident, CVA, commonly called a stroke, third leading cause of death, commonly called a stroke. Blood circulation is blocked, causing ischemia, and that starves the cells downstream. 80% of people die on the first attack. The remaining 20% have some form of disability. A TIA, where the patient has a short-term symptoms of a stroke, but it clears. Some degenerative brain disorders, Alzheimer's. Alzheimer's was a deficit of acetylcholine. Parkinson's, degeneration of the dopamine-releasing neurons of the basal nuclei. Remember our symptoms of the Parkinson's guy? Pill roller, loss of facial expression, doesn't swing his arms, shuffling gait, loss of facial expression. Parkinson's. Huntington's disease, a hereditary dominant, where the patient winds up as a shaking mass in about 15 years. The spinal cord begins at foramen magnum and runs all the way down to L1, L2. In the adult, there were 31 pairs of spinal nerves that exit from the vertebra. The cross-sectional anatomy. Remember, we drew a cross-section of our spinal cord, and we had the whole thing all hooked up. And remember our DRG, dorsal root ganglia? And we said that made it the dorsal part, and if you can find the DRG, then you can label all the other parts, because dorsal is posterior, ventral is anterior. And remember, we had an anterior median fissure that was a deep crack, and a posterior median sulcus that is a shallow crack. We drew all that up on the board for us. We talked about the tracks, the pathways inside of the CNS. The ascending tracks carry sensory information up through the first, second, and third order neurons. There were 6 main pathways. The most important was the lateral and anterior spinothalamic. It carries pain, temperature, deep pressure, and coarse touch. Lateral and anterior spinothalamic. Pain, deep pressure, and coarse touch. The descending tracks, 2 neurons in a row, the upper motor and the lower motor. Spinal cord trauma, paralysis, loss of motor function. Paresthesia, loss of sensory function. Some diagnostic procedures, reflex tests, pneumoencephalographies, cerebral angiograms, CTs, MRIs, xenon scans, PET scans. All of those are diagnostic procedures, all of them. Some developmental aspects, CP, cerebral palsy, loss of oxygen before or during delivery, encephaly, where the cerebrum and parts of the brain stem do not develop. Spina bifida, incomplete formation of the posterior elements of the spinal vertebra. Hydrocephalus, overproduction of cerebrospinal fluid. Aging and our CNS. No appreciative decline until the 70s, about 5% per year after that. The PNS that we did tonight, everything outside of the CNS, including sensory receptors, the peripheral nerves, and their associated ganglia, as well as the efferent motor endings. Our sensory receptors, we classified them by their stimulus type: mechanoreceptors, thermoreceptors, photoreceptors, chemoreceptors, and nociceptors. We classified them by their location. Exteroceptors get their stimulus from outside the body. Interoceptors get their stimulus from inside of the body. We classified them by their complexity. Simple, most of them associated with the general senses, and complex receptors associated with the special senses. We classified Mesner's and Pacinian corpuscles. Remember, it was an exteroceptor because it was light touch. It was mechano because something was moving, and it was simple. So Mesner's and Pacinian, extro, mechano, simple, receptors. We talked about sensory integration, and it was sensation versus perception. Sensation was what we feel. Perception was how we feel about what we feel. We talked about adaptation. An unchanging stimulus gets ignored after a time. Adaptation. Unchanging stimulus gets ignored with time. Nerves. A bundle of axon enclosed in connective tissue. And there was endoneurium, perineurium, and epineurium. The fibers, the axons, could be mixed, sensory, or motor in the spinal nerves. A ganglia, a bundle of neuron cell bodies in the PNS. Regeneration. Some regeneration occurs in the PNS, none in the CNS. No regeneration occurs in the CNS. The motor endings, the axon terminals, are boutons, formed our neuromuscular junction in our somatic. Varicosities in the autonomic. Varicosities were swelling, and we're going to spend more time on those next week after our test. We looked at our nerve branches called rama, branch of a spinal nerve. The dorsal ramus goes to the back, the skin and muscles of the back. The meningeal branch goes to the meninges. The rama communicates, or white fiber, white ramus. It communicates with the autonomic nervous system. The ventral rama, the front of the body. They form plexuses, and we looked at our dermatome guy. Remember the dermatome guy? We looked at levels of motor control, and there were levels where we controlled it, just like in the somatics. We had some terms: synergy, coordination of the agonist and the antagonist. Loss of synergy gives us ataxia, slow, tentative, inaccurate movements. The basal nuclei damage gives us dyskinesia, bad movements. We talked about the reflexes. There were three things that a reflex was a response to a stimulus, and there was three things necessary for us to call a response to a stimulus a reflex. It had to be involuntary, it had to be rapid, and it had to be predictable, all of those. And the reflexes have an arc beginning with a receptor, a sensory neuron, an integration center, a motor neuron, and an effector. The spinal reflexes were the somatic reflexes mediated by the spinal cord. There were stretch reflexes, deep tendon reflexes, flexor reflexes, and crossed over reflexes. The superficial reflexes could be stimulated by general cutaneous stimulation of the skin. Plantar reflex on the base of the foot, and that's when we saw Babinski's sign. Not Babinski's reflex, Babinski's sign. If a Babinski sign after the patient was a toddler indicated upper motor neuron lesion. All right, you guys good? Test next week. After the test, we're going to do the autonomic nervous system.